Okay, on the next several slides, I have the learning objectives that we're going to be discussing throughout the lecture today. I won't read those to you, but I'll just pause on each slide so you can look at them on your own. In your MedSurg textbook, the neurological system is chapter 41 through 45. We're going to talk about 41 and 44 more in depth, and then just a few things about some critical care type things in chapter 45 we will discuss as well. But we're going to start at 41 with assessment of the nervous system. It's helpful, I always think, to have a review of the anatomy and physiology of the body system that we're talking about, just because I know you guys did have to have anatomy and physiology as a prerequisite before coming into the nursing program. However, I know that in real life, we don't always remember those things that we learned in A&P. And so if we can review those, then it will make more sense once we start talking about the pathophysiology and the different diseases and things that can happen within the neurosystem. Okay, so the nervous system is divided into two parts. It's the central nervous system and the peripheral nervous system. So the central nervous system has your brain and your spinal cord, and then your peripheral nervous system is divided into your somatic and autonomic systems. The autonomic nervous system is that parasympathetic and sympathetic that we've talked about in other lectures, or you've talked about, I'm sure, in other lectures. There is actually a third part of your nervous system, and that is called your enteric nervous system. So if you've heard of that, sometimes doctors will call this the little brain, and this is your GI system. So your GI system actually has its own sort of nervous system, and as kind of a fun little tidbit, I've always thought this was really interesting, that your GI system actually has as many neurons as your spinal cord. All right, so let's talk about the first part of our central nervous system, which, as you remember, has the brain and spinal cord, but let's look at the brain first. So here is I like a good picture of your brain because it shows the color-coded parts and different lobes. So there is also a box in your book on page 831 to 832 that goes over the major functions of the cerebral lobe and the brainstem. But this is just a little overview here. So the frontal lobe is the largest lobe, and this is what deals with your memory, your cognition, emotions, judgment, abstract reasoning. It's kind of like the place of our higher brain function. So the things that make us really smart. An important area that we have in the frontal lobe is called Broca's area, which you may have talked about when you talked about sensory. Broca's area is responsible for our ability to form words in speech. Okay, next in red we have what's called the parietal lobe, and this deals with our different senses and our ability to feel different sensations. So things like our visual perception, pain, and touch sensations all are dealt with here in the parietal lobe. Okay, next we have the temporal lobe, and that's down there in the blue. It does several things, most important probably being that it interprets sound. It does deal a little bit with long-term memory, but it also contains an important area called Wernicke's area. So this is another language area. Wernicke's is what allows us to understand speech or understand written or spoken words and language. So Broca's helps us make speech, and Wernicke's helps us then understand speech. And the reason we talk about that is sometimes if we have damage to those certain areas, like in a stroke, then you will see that someone may be able to express speech but not understand it, or understand speech but not express it. And so we know that that kind of helps us pinpoint a little bit on where the damage is in a CVA. I have seen some research lately that neuroscientists are starting to think that the language centers of our brain are much more complex than they originally thought. But for our purposes now, we aren't neuroscientists, so we're just going to keep with the simple old explanations of Broca's and Wernicke's. All right, next we have the temporal lobe. Oh, sorry. Next we have the occipital lobe in green there at the back. And this is the primary visual center of the brain. Sometimes you will hear the occipital lobe referred to as the visual cortex. And lastly, we have the cerebellum, and that is there in kind of like the teal color. That receives information from all of our senses, and it helps us regulate our motor movements. We also have our brainstem, which is in a lobe of the brain, but is very important for sustaining life in humans. So the brainstem is part of the lower brain. It actually has 3 parts that aren't shown here, and you don't really need to know, but if you ever hear these words, the brainstem is made up of what's called the midbrain, the pons, and the medulla. Your brainstem is primarily concerned with providing the basic functions that keep you alive. So things like your reflexes, your basic wakefulness. It's important to know that no higher level processing takes place here. So if we kind of look inside the brain or look at a cross section here, we can see the thalamus and the hypothalamus inside. And then as you remember, the medulla is just a part of the brainstem, just like this picture, because it's not always easy to see in some diagrams, a picture of a thalamus and the hypothalamus. The thalamus is sort of like the central nervous system's switchboard, so it helps to tell the signals where they need to go once they arrive. And the hypothalamus is what helps regulate our autonomic nervous system. So as you remember, your sympathetic and your parasympathetic nervous systems. The hypothalamus, if you talked about this when you talked about hormones and things, it also plays a role in your endocrine system, where it regulates the secretion of pituitary hormones. So you may wonder, you may already know, but why is your brain wrinkled up like this? The reason that we have these wrinkles in our brain is because the folds increase the surface area. So think if you have like curly hair, it looks shorter, but if you straighten it, it looks longer. So this process of forming these folds is called gyrification. The peaks of the folds are called gyrus, and then the troughs there are called sulcus. So those just let us have more surface area in a smaller space. Okay, so don't freak out too much on this slide. It's just to show you that the brain really has quite a bit of a protective layer covering it. So you can see here we have the skin of the scalp, and then we have the bone of the skull. The outside layers right here are called the dura mater, and then we have the middle layers, which is the arachnoid mater, and then the most inner layer is called the pia mater. So underneath the arachnoid space underneath the arachnoid space and before the pia is a little space called the subarachnoid space, and you can see it right here. So inside that space is actually where the cerebral spinal fluid circulates, and the purpose of cerebral spinal fluid in the brain is literally just to provide cushion to the brain and the spinal cord. So together, all of the protective coverings of the brain and the spinal cord are called the meninges. So where have you heard this word before? Okay, so you may be thinking meningitis, and that's correct. So meningitis, then we know, is the inflammation of all of these protective coverings of the brain, and we'll talk about that a little bit later. This picture just provides us a little snapshot of what the blood flow or the cerebral circulation looks like within our brain. You don't need to know the names of the vessels and things like that. It's very confusing and complex. But just know that your brain does require a lot of blood flow, and that's just because it uses up a lot of energy to perform its task that it does within our body. An interesting thing about the circulation system within the brain that's a little different than the circulation in our bodies is that the capillaries within the brain are joined very tightly together in what's called tight gap junctions. So in our normal circulation system, I'm just going to try to draw down here. I'll show you. The cells or the gap junctions within our normal circulation within our body have these little spaces in between that allow things to flow in and out of the capillaries relatively easy. However, within the brain, let me erase this. Within the circulation in the brain, the cells or the gap junctions are drawn. I'm a terrible artist, so you're just going to have to go with it. Hopefully you'll understand the point. The gap junctions are very, very small, and this serves a really important protective function for our brain, because although these little small junctions let some things through, like oxygen, glucose, and water, and we want that to happen because our brain needs those things in order to perform its functions, but it keeps out things like bigger molecules and proteins. So it keeps things such as medications and other things that we don't want leaking out of the capillaries into our brain. It keeps those out. And that does help protect our brain from toxins and things that could affect our body. It gets through within the circulation in our bodies. But our brain can be kind of fragile, and so we want to keep those things out. So your brain does that sort of as a protection mechanism. However, this can present problems because sometimes medications that we want to target the brain have trouble getting through that blood-brain barrier, and so we have to sometimes have special medications that are able to have smaller molecules that can get through those tight gap junctions. Okay, so the second part of our central nervous system is our spinal cord and our spinal column. So this just is kind of a cool picture because it shows the different regions here. The spinal cord is protected by the spinal column. You may have talked about this in musculoskeletal. So we have our cervical region there at the top, our thoracic, our lumbar region, the sacral region, and then the coccygeal region. So if the brain is the ultimate center of our thoughts, then we can kind of think of the spinal cord as the highway that connects our bodies to our brains. The spinal cord is about 40 to 50 centimeters long. It extends all the way from the base of that brainstem to the lumbar vertebrae. And it has ascending and descending tracts that you can see there that carry the signals up and down, so back and forth from the body to the brain. It's the tracks are really complex because there's different types of tracks and they only carry certain information such as pain. You don't need to know all that, but just know that it has these ascending and descending tracks. So how does the nervous system actually carry these signals or transmit these messages between the body and the brain? The actual functional unit of the nervous system is what's called a neuron. And the nervous system is made up of tons and tons of these neurons that transmit impulses or messages. Some of the neurons in your body are sensory, which allows us to receive information through our senses. And some of our neurons are motor. So that's what allows our ability to have purposeful physical movements and to be mobile. The neuron is made up, if you look over here, the neuron is made up of the cell body, which is also called the soma. So here at the top, the cell body. Branching processes that then come off the cell body are called dendrites. These little tree branch looking things that come off. And then And then coming down off of the cell body is what's called the axon. And we'll talk a little bit about how these work. But basically, neurons work by transmitting an electrical signal. It's also called an action potential to another neuron, and which then transmits it to another neuron, and etc. until it gets to its path where it's going. So some axons, remember down here, are covered by something called a myelin sheath, which acts sort of like an insulation, or if you think about a wire, and I show you a picture later, if you think about a wire that has the metal parts inside, but it's kind of covered by a sheath, like a plastic sheath, that helps to provide insulation for the electrical signal. So that allows our body to signal or to transmit the signal much more quickly, and it also allows for not having much loss of electricity or loss of signal as it travels through these neurons. The node of Ranvier basically is just the little spaces in between here on the axon, and that allows the electrical signal to sort of jump from one portion to the next portion, and it actually helps the signal to travel much more quickly. So how does the signal get from one neuron to another neuron? Well, this shows you an example of that. So we see a picture of a neuron here. Remember, here's the cell body, and then we have these little dendrites coming off, and then we have the axon where the electrical signal travels, and then it gets to the end right here, and neurons don't actually touch each other. So there is a point though where they almost touch, and that is what is referred to as the synapse. So once the electrical signal comes down this axon and it gets to the end, and a whole bunch of really complex chemical changes that you don't need to know occur, but just know that that allows for the release of something called a neurotransmitter. And that neurotransmitter gets put here into this synaptic cleft. So the synaptic cleft, and then that triggers the other neuron to see those and the signal to continue then on to the next. This process occurs incredibly quickly from neuron to neuron. And that is what allows the transmission of the signal in our nervous system, or the message within our nervous system, to travel or be transmitted. So you probably heard the word neurotransmitter before, and hopefully you kind of understand now a little better what that means. There are tons of neurotransmitters, but for the purposes of this lecture, we will just talk about some of the ones that are much more common, especially when it comes to functions of our body and disease processes, and then some of the medications that we use as well. So really what we're going to discuss are these ones in this lecture are these ones that are in capital letters, so acetylcholine and dopamine. And we're going to talk about what happens when things negatively affect acetylcholine and dopamine within our body. So acetylcholine is a neurotransmitter that activates skeletal muscle. And we have dopamine, which has lots of functions, and most people probably think about it in relation to our pleasure and our reward system, our reward center. But another really important function of dopamine is it helps to regulate our motor behavior. And when we talk about things like Parkinson's, it will make more sense how this can go wrong. So here is another picture I have showing you the end of an axon, the synaptic cleft right here, and then these little circles right here are, I think, supposed to be neurotransmitters. So you can see that's the chemical, or the electrical signal comes down that axon. There's a chemical process that causes the release of neurotransmitters like acetylcholine and like dopamine into this synapse, which then signals the other neuron to continue that signal on. So as we can see, definitely if something is interfering with, or you have a decreased amount of neurotransmitter, then the signal from one neuron to the next neuron is not going to transmit as well, or there's going to be issues with that. And we'll talk about that in relation to the disease processes as we go through the lecture. So in summary, the central nervous system basically coordinates and controls all activities of the body. So it receives stimuli from both the internal and the external environment, helps to communicate information between different parts of the body. It computes and processes information, and then it transmits information between the different systems. Okay, so now that we've talked about the central nervous system, we're going to talk about the second part, or the peripheral nervous system. The PNS is a collection of nerves outside of the central nervous system, and it consists of 31 pairs of spinal nerves. It also has the cranial nerves, and it has the autonomic nervous system. So the spinal nerves have two branches, or two pathways there. The afferent pathway is what carries sensory information, and then we have the efferent pathway, which transmits motor impulses. So they use different pathways. In your book on page 834, there's a cool picture of how the different spinal nerves help to innervate different parts of the body, and shows how different areas of our body are controlled by different spinal nerves. And these different areas are called dermatomes. And so your book kind of gives an example that someone with an injury to the spinal nerve C6 and C7 might have sensory changes to several parts of the hand. You don't need to memorize that. It just kind of gives you an understanding of how those spinal nerves help to innervate different parts of the body. And we're going to talk a little bit about the cranial nerves and the autonomic system on the next slide. So at this point of your education, you may have heard of the cranial nerves before. Basically what the cranial nerves are nerves that emerge directly from the brain. There are considered to be 12 pairs of them, and these cranial nerves help to relay information between the brain and other parts of the body. So the 12 cranial nerves either have a sensory function, a motor function, or they have both. And why we care about them as nurses is that their assessment is very important for a patient who has a neurological problem or a suspected neurological problem. I have a brief diagram here of each nerve's name, type, and function. There's also a much more extensive table on page 835 in your books. Don't really expect you to know all of that extra information at this point in your education, but what's important is that you know how to assess them. And I have placed within Canvas in your module a cranial nerves cheat sheet that goes through each of these, its classification, its function, and then also has a box to talk about how it is assessed. So definitely please check that out. The cranial nerves can be hard to remember, so I do have a few mnemonics on here that may help you. This is a common one here that helps you to remember the names and their function, whether they're sensory, motor, or both. I also like this for the more visual among us, because it not only helps you remember what the cranial nerves are, but it helps you to remember what the cranial nerves do and control. So it has a 1 there for his nose instead, so that helps to kind of tip us off that that's olfactory, whereas 2 on his glasses can help remind us that it's optic. So if you're more visual, you might find this one helpful. This is just kind of a personal favorite of mine for the names anyway, because I'm a huge Harry Potter fan. And it says, on they traveled and found Voldemort guarding very ancient Horcruxes. Anyway, about 1 million of these mnemonics exist, so it's whatever works for you. Okay, so now let's talk about the autonomic nervous system. Remember, this is the one that contains 2 parts, the sympathetic and the parasympathetic. So the autonomic nervous system is what helps us to control our involuntary muscles, such as our smooth muscle, our heart, different glands in the endocrine system, for example, the adrenal medulla. And then the picture here shows some of the actions of the parasympathetic nervous system. So stimulating the flow of saliva, slowing the heartbeat, constriction of the bronchi, stimulating peristalsis and secretion, and contraction of the bladder. And it also on the right hand side here has the functions of the sympathetic nervous system. So dilation of pupils, inhibits the flow of saliva, accelerates the heartbeat, dilates the bronchi, and inhibits bladder contraction. So you can see that these kind of have opposing functions. Let's talk about it in a little bit more detail here. So our sympathetic nervous system is responsible for the activation of what we think of as our fight or flight response. So it's what prepares you for situations that might be stressful or life endangering. It kind of helps me anyway to remember the different actions if I imagine what my body would do if I was being chased by a bear. So being chased by a bear would definitely activate the fight or flight or your sympathetic nervous system. So if I was being chased by a bear, like the people in this photo, my heart and my blood pressure, my heartbeat, blood pressure would definitely go up. My airway or my bronchi would dilate so I could get more air in. My pupils would get bigger, so they would dilate because I would need to see better and react to this whole situation. And then my GI system would actually slow down because it would say, no, now is not the time to worry about digesting food. We need that energy for something else more important. So my GI motility actually would go down or decrease. So remember we talked about the neurotransmitters, and the sympathetic nervous system has two primary neurotransmitters, and those are epinephrine and norepinephrine. The parasympathetic nervous system basically does all of the opposite. So it causes our blood vessels to dilate, it causes a decrease in our blood pressure and heart rate, it increase in our salivation, it causes our pupils to constrict, and then we have an increase in GI motility. And the primary neurotransmitter of the parasympathetic nervous system is acetylcholine. Okay, so I know you've had the adrenergic cholinergic lecture already, but I just want to review it here because I know that we, forget things from week to week, sometimes from day to day if you're like me. So first we'll talk about the adrenergic drugs. And what adrenergic drugs do is they produce similar effects in the body to what happens when our sympathetic nervous system is stimulated. So as you remember, that's our fight or flight. So the adrenergic drugs kind of mimic what your sympathetic nervous system does. So this would have effects on the heart and the blood vessels and the bronchi. So what do these do to you then? So if you remember what happens when our fight or flight kicks in, we'll have things like constriction of our blood vessels. We would have an increased heart rate, and then we would want more air because we're dealing with a stressful situation, so they bronchodilate as well. So examples of adrenergic drugs are epinephrine, which makes sense because remember that is the primary neurotransmitter of this system, so we can take it from outside our body as well. So epinephrine, ephedrine, Sudafed, and dopamine are all adrenergic drugs. And you will see that these are often used for things that affect our heart and that affect our airway. So things when we want to increase our heart rate and when we want to dilate our bronchi. Okay, so next we have the opposite, anti-adrenergic drugs. So these would be drugs that block the effects of the sympathetic nervous system. So namely your alpha blockers and your beta blockers. So things that block the effects of the sympathetic nervous system are going to basically cause the same symptoms of our sleepy baby slide. So the slowed down parts of our parasympathetic nervous system. which makes sense because beta blockers are one of a very common class of drugs we use to treat hypertension. And we know that those decrease the blood pressure. So those work to block our fight or flight, causing our blood pressure to decrease. Okay, so next we have cholinergic drugs. These are the drugs that stimulate our parasympathetic nervous system or stimulate our inner sleepy baby. So some examples of these: acetylcholine, neostigmine, and tensilon, which we'll talk a little bit about how these work in different disease processes when we go through those. But cholinergic drugs mimic the parasympathetic nervous system. So they cause things like slowed heart rate. They can cause dilation of blood vessels, and they can also cause increased secretions because remember our GI system and salivation actually increase with our parasympathetic nervous system. And all of these cholinergic drugs all mimic the action of acetylcholine, which you remember is the main transmitter of the parasympathetic nervous system. And lastly, we have our anticholinergic drugs, which then block the action of the parasympathetic nervous system, namely by blocking the action of, if you remember what is the primary neurotransmitter of the parasympathetic nervous system, and that is acetylcholine. So it blocks the action of acetylcholine. So what are we going to see if we're blocking the action of the parasympathetic nervous system? We're going to see things that speed up and provide CNS stimulation instead. So namely, these medications are used to stimulate the CNS, to decrease secretions, especially prior to like surgery and things like that, to decrease GI motility. So that's how scopolamine works. Like if you've ever taken that for motion sickness, that's because it causes a decrease in GI motility. And then Atrovent, for example, is something we take with asthma, and that causes bronchodilation. So all of those things because we are blocking the action of the parasympathetic nervous system. So we're going to see them causing symptoms that more mimic the sympathetic nervous system. I know that's kind of confusing, but hopefully you can sort of see how those work. So now that we have some of our basic A and P out of the way, which will help us later, let's talk about the different assessment methods for the neurological system. So we're, of course, always going to want to know demographic data, so age and gender. We also want to know past medical history. So things specific to the nervous or to the neurological system, you might want to know about chronic diseases, if they'd had any past neuro issues. For example, seizures, headaches are an important indicator of neuro issues as well. If they'd had a history of any type of injury to the brain, so had they had a CVA, had they had a car accident, had they ever had a concussion. We also want to know what their current symptoms are that they're experiencing on the problem that's bringing them in. So we want to know in their own words kind of what's been going on. Have they been having headaches? Have they been having changes in their vision, weakness, decreases in their ability to do ADLs or motor activities? And then finally, never neglect the social history in any type of assessment. So what are their sleeping habits? Where do they work? Do they use drugs and alcohol, etc.? Okay, so when we start upon our physical assessment, we want to make sure that we assess their mental status. A mental status exam should include the patient's level of consciousness, their orientation, and their cognition. Level of consciousness especially is a really important indicator of neurological function. Level of consciousness is a measure of the patient's wakefulness. So don't confuse level of consciousness with orientation to person, place, or time. Those are separate things. So level of consciousness ranges from alert to coma. If they're easily engaged and awake, then they are alert. So if they do not rouse despite you vigorously stimulating them, then they may be closer to the coma side of the scale, which we'll talk about some different ranges of level of consciousness, I think, on the next slide. Also, we have orientation, and that is a measure of the patient's orientation to their surroundings, namely their person, place, and time. And you get this information by questioning the patient directly, such as asking them the year and the month, asking what their address is, what the name of the building that they're in is. In patients without a suspected neuro issue who seem to be carrying on a conversation relatively fine and referencing where they are and all of that, then some of this can be assumed directly without asking. So if you're doing a neuro assessment on somebody or assessing orientation on someone who really isn't there for any issues related to confusion and they seem to be talking to you fine, we don't necessarily have to ask them, what's your name, what's your address, because we can just sort of assume that they would be able to answer those because they're able to carry on a normal conversation with us and don't have any signs of not being oriented, if that makes sense. Also, we need to assess cognition, and cognition is an assessment of intellectual function. So memory and the ability to sustain attention on tasks. So how do you think we could test remote memory? So remote just means further away, longer time has passed. So remote memory, good ways to test that are when was your birth date and what elementary school did you attend would be good questions for remote memory. So what about recent memory? When they were admitted, what is their doctor's name? And then we have immediate memory and the ability to create new memories. That can be tested also there. And it's most commonly assessed by giving a patient 3 easy words like apple, ball, chair, and then having them repeat those to you. And then the other part of testing cognition is assessing attention. And this is the ability of the patient to sustain attention on their environment. And of course, we all kind of have squirrel moments, but with some mental processes like delirium, you will notice that the patient has a really hard time maintaining attention. And that is actually the hallmark of delirium and why we assess this. So one way to test attention is something called the serial sevens. So you have them start at 100 and then count back by sevens. And this isn't necessarily a test of their ability to do math. It's a test of their ability to maintain focus during that task. So I always think of, I've always heard that if you get pulled over for drunk driving and they have you do your ABCs backwards, the point isn't really to know that you can say your ABCs backwards. The point is to see your actions while you're doing so. So someone with delirium or who has a problem maintaining attention may not be able to focus at all on doing this task. So just kind of get distracted by other things and not maintain their attention on it. And so again, remember just that cognition is a test of memory, concentration, judgment, intellectual functions, whereas level of consciousness is a test of alertness. Okay, so levels of consciousness, different terminology we can use. Alert, this just means alert to the environment, responds appropriately to commands and questions with minimal stimulation from you. Confused means that they are disoriented to surroundings. They might have impaired judgment. They may need cues to respond to commands. Then we have lethargic. This means drowsy, that they might need gentle verbal touch or stimulation to initiate a response. And do please remember there's a difference between you just woke them up and they're still sleepy to actually being lethargic. So if you come in to assess a patient's LOC and they were right in the middle of a great nap and you have to wake them up with some verbal stimuli and they act a little bit drowsy, this doesn't really mean that their LOC is lethargic. once they actually kind of roused and got around, then I imagine they would be alert unless there was an issue. So give them some time to wake up before saying, you know, patient is lethargic. Lethargic is more for someone who, I always kind of think of sometimes patients who may be a little bit over medicated with some things. So they're just sort of drowsy all day and, you know, in and out of sleep, and you can try to wake them, get them really alert, but it just doesn't seem like it takes quite a bit of effort to do so. That would be a time when you would say that a patient's LOC is lethargic. So hopefully that makes sense, the distinction there. Then you have what's called obtunded, which means that they respond slowly to any type of stimuli and that they need repeated stimulation to maintain their attention and their response to the environment. So just kind of, I would say, just kind of out of it, and you have to really repeatedly stimulate them or question them in order for them to respond to you. Then we have stuporous. This means that they respond only minimally, even after vigorously stimulating them. And they may even moan or just mutter as a verbal response, regardless of how much stimulation that you get them. And then lastly, we have comatose. And this is no observable response to any external stimuli, regardless of you trying to stimulate them. So always know, very, very important, that a change in level of consciousness can signal something neurological, and it must be assessed. So has anyone ever had a concussion? They probably told you in the discharge teaching, if you went to the hospital, to come back if your caregiver noticed any changes in consciousness. So a change in consciousness can signal a really serious problem, and we'll talk about some of those processes later. But just know that any time that occurs, it needs to be taken very seriously, and that we should know as healthcare professionals that it could signal that something could be going wrong with the patient. Just going to briefly show you this. You'll go over this in much more detail next year once you get to level 2 when you talk more about critical care. But just know that the Glasgow Coma Scale is a numerical scale that measures level of coma. So the higher the score, actually the better, with 15 being the best score you can get, 8 or less being some level of coma, and this is here at the bottom, or a 3 or less being completely unresponsive. And the score is based on 3 categories, and that's eye-opening response, best verbal response, and best motor response. So it wants to know, is the patient spontaneously opening their eyes, or are they only opening their eyes to speech, or are they only opening their eyes to pain, or is there no response at all? And then it follows a similar format for the verbal response and the motor response. So the physical assessment for the neurological system also includes assessment of motor function, because we know that our nervous system also helps to control our ability to have purposeful movement and motor function. So testing motor function starts out just with your general observation of the patient. Do they seem to have any tremors or any involuntary movements? Do their movements seem too slow or too fast? What does their balance look like? What does their gait look like? We also want to assess their strength, and that's something that we will do in conjunction with physical therapy. You already know how to assess hand strength by having the patient to grasp and squeeze your hands. You can also test for strength against resistance by bending or straightening the arm and having them push or pull against you. And then we'll talk about posturing on the next slide. Okay, so in here I have an example of abnormal posturing for patients that signal and usually pretty serious issue within the neurological system. A is what is called decorticate posturing, and B is called decerebrate posturing. Decorticate posturing is the abnormal flexion of the arms at the elbow, the wrists, and the hands. As you can see there, they are flexed, along with extension of the legs. So you can see that the toes are extended there. And this signals, decorticate posturing signals that there is some type of dysfunction going on in the brain, but above the level of the brainstem. And then we have B, decorticate posturing, and this is abnormal flexion of the arms, but with hyperpronation of the forearm. So you can see that there in B. This is actually a really, decerebrate posturing is a really ominous sign, as it signals that there is a problem within the brainstem. So usually a very poor outcome or prognosis for patients when this is happening. As you remember, the brainstem is responsible for all of those like very innate functions that keep us alive. So with decorticate, it still signals that there's a problem there in A with higher brain functioning, but still a chance that it's something more fixable, whereas in B, an issue with the brainstem is more of a poor prognostic sign. Okay, so testing the reflexes is something that also goes with a neuro assessment. The deep tendon reflexes are a sign of what's called an intact reflex arc, which is a good neurological sign. Basically, what that means is that your neurons are working correctly to transmit that sensory and motor information. And it takes practice to hit them in the right place, I think. You have to use your reflex hammer, making sure that you're striking quickly, but not with too much force. If the reflex is hyperactive, then this can indicate a problem with your upper motor neurons, or it could also tell us possibly an electrolyte disturbance, namely hypocalcemia. Hypoactive reflexes or underactive reflexes indicate a problem with the lower motor neurons and can signal that there may be damage to the spinal cord, that different muscle diseases might be present, and then also can signal another electrolyte disturbance, which is hypokalemia. You've talked about Babinski's sign with newborns in maternal child and how it is a normal inborn reflex in the newborn. However, it should go away as the child grows. So normally between 12 months to 2 years, you will see that the Babinski sign actually should disappear. So know that a positive Babinski reflex in an adult is always abnormal. So to elicit a Babinski or test for a Babinski sign, you want to use the sharp end or the other side of a reflex hammer and sort of draw it along the bottom of the foot like I have there in the picture below. A positive Babinski sign is where the toes fan out, and this would be abnormal. And it's a sign of some type of problem within the central nervous system. May see it in multiple things: head injury, alcohol and drugs intoxication, and spinal trauma. Just a few diagnostic assessments for the neurological system. Not really going to go into too much depth here. Labs, always going to run a lot of labs if there's a neuro issue. We want to look for fluid and electrolyte levels, if there's any abnormalities with glucose. Might check an ABG or the arterial blood gas for oxygenation status. Always going to do a tox screen and a drug panel if we have any abnormal neurological signs. And really any of these being out of whack can lead to neurological manifestations. X-rays, namely of the skull and spine, the CT or an MRI, and then an electroencephalography or an EEG, and that's where they hook you up to those all those electrodes on your head, and that helps to record the electrical activity of the brain. Okay, a lumbar puncture, aka a spinal tap, is one test that is done in the clinical setting for many reasons. Sometimes they want to see what the actual fluid pressure is of the cerebrospinal fluid. Sometimes they want to obtain a sample of the CSF to analyze it for infection. And then this is also sometimes how some anesthetics are given, like epidurals or spinal blocks. So with the patient in a flex position, like here in the picture, we want to have them kind of flex because that maximizes the space between those vertebrae. For a lumbar puncture, the needle is inserted there in between L4 and L5, and that helps us gain easier entry to the subarachnoid space. So obviously during an actual procedure, the patient would be gowned and draped to protect their privacy, but this allows you to see the positioning and where the actual puncture should take place. This gives some examples of what cerebral spinal fluid may look like. A is normal. It should be clear, should be free of any cloudiness or discolorations. B is an example of what it would look like if you had blood in your cerebral spinal fluid. This could result from what's called a traumatic or bloody tap. That can just occur as kind of as a result of the trauma of inserting the needle and things like that. So if that's the case, then they usually will test subsequent tubes to see if that's lessening. However, if the blood isn't lessening, then that can be a sign of some sort of hemorrhage going on in that subarachnoid space. C is just centrifuged CSF that had a little bit of blood in it from a traumatic tap, but you can see that once they centrifuged it, it's relatively clear. D is cerebrospinal fluid from a patient who has a subarachnoid hemorrhage. So there is blood at the bottom of the tube, and then you can see even after they centrifuged it, it still has like an abnormal color. It's yellow. And if cloudy, as you can see kind of in the bottom, there's a few that are more cloudy and kind of yellowish, then that can indicate infection. So you don't really need to memorize all of that and what they're supposed to look like, but just know that in a normal tap, it should be clear, not cloudy, and that cloudiness can definitely indicate an infection. Okay, so that was our assessment considerations and some little bit about diagnostic tests for the neurological system. Now we're going to actually talk about problems that can go wrong within the nervous system, and these are separated out. So first we'll talk about problems, care of patients with problems with the central nervous system in the brain. Then we'll talk about care of patients who have issues with their spinal cord, and then we'll talk about issues with the peripheral nervous system. So with the brain, and I like this picture here, it's an MRI of a brain of a patient with Parkinson's disease. And you can kind of see that the gray matter, and remember when we talked about those folds, the gyri and the sulci, that there are significant reductions in the folds of this brain, and that is common to see in Parkinson's disease. Okay, so one of the most common things that you'll see going wrong in the central nervous system for patients is headaches. Most common of all physical complaints, in fact, that people present with to their doctors. And it's important to know that headaches are a symptom rather than a disease in itself, but they may indicate some sort of organic disease process going on. Most commonly, though, a response to stress. Vasodilation can also be a cause of headache. So our circulation there in our brain, we have a dilation of the arteries there. And that is actually why that caffeine can sometimes help with headaches and migraines, because we know caffeine stimulates us and causes vasoconstriction. So it kind of treats that dilation of the blood vessels. It's leading to pain and headache. And then also headaches can be the result of just skeletal muscle tension, and these are referred to as tension headaches. Okay, so the most common type of headache that's going to cause a person to seek medical treatment is a migraine or a cluster headache. And so those are the two that we're actually going to talk about. The cause of migraine isn't fully understood, but they know that it has some relation to vasodilation and inflammation within the brain. Some patients can even tell when a migraine is coming on because they will get what is called an aura, which is some type of sensation or a visual change that then signals the patient that a migraine is starting. Once the migraine starts, the person is going to have intense throbbing pain. They may also have nausea and vomiting. They may have photophobia or sensitivity to light, or they may have phonophobia, which is sensitivity to sound. So you'll see patients sometimes who have migraines, they report going like into a dark room that's very quiet, and that can help. Multiple medications, multiple classes of medications are used in the treatment of migraines. For example, they might use NSAIDs, they might use beta blockers and calcium channel blockers. Triptan medications are also used quite a bit. I think most of these are given by injection at the start of a migraine. But one of the more common ones you guys might have heard of is called Imitrex. And there's more there about treatment on page 855 in your book, table 42.1, so make sure that you review those. Another type of headache that people frequently seek treatment for is what's called a cluster headache. And it is an incredibly painful but short headache that lasts from 30 minutes to about 2 hours. And it's unilateral, so meaning that the pain is felt only on one side. And usually this is going to be behind or around the eye. And the patient may have a runny nose, they may have a drooping eyelid, they may have eyelid swelling even on the affected side. And treatment is kind of all over the place. They often will try to use the same meds they use for migraines. Sometimes they'll use steroids, sometimes they even use melatonin. I think your book says sometimes they even use lithium, which is actually a mood stabilizer. So treatment is kind of a work in progress for these. And I have a video here of someone who, or I think a few people who experience cluster headaches. It gives you a good idea from the patient side. So go ahead and have look at your PowerPoint slides and play this video before going on to the next slide. We're going to spend the next several slides talking about seizures. So one thing I want to make clear though at the get-go, it's important to realize that seizures and the actual diagnosis of epilepsy are not the same thing. So seizures can happen to anyone for reasons that aren't related to actually having the disease of epilepsy. A seizure itself is sort of the result of a abnormal, sudden, and excessive amount of electrical discharges of the neurons of the brain. So remember how we talked at the beginning about neurons and how they work using electrical conduction. So you can see in this short little clip here that shows a good example of transmission of electrical impulses in the neurons. And when seizures occur, it's sort of just your brain goes crazy with these impulses and they aren't actually transmitting correctly, and just a very uncontrolled, sudden, and excessive amount of discharges of the impulses going on in the brain. Seizures come in several types. So you have generalized. These usually involve both cerebral hemispheres, and they cause the type of seizures that you're more used to seeing, like in movies and TV. So real seizures, if you have seen them, are not quite like it shows in movies. A generalized seizure will usually start with a person being very rigid or stiff, and this is called the tonic phase. And that is then quickly followed by the rhythmic jerking of the extremities, or the clonic phase. So generalized seizures are sometimes referred to as tonic-clonic seizures. Partial seizures are local seizures that only affect one part of the brain, so it may be localized to just one area, such as the face. And then epilepsy as a disorder is diagnosed after someone has had 2 or more seizures. And it may be related to some sort of abnormality in the electrical system of the brain, or it may be from an unknown cause, or idiopathic, which we talked about the meaning of that word in hematology. Okay, so although sometimes seizures seem to occur for no reason, there are some things that increase the risk, and here are some examples. So acute alcohol withdrawal will often see seizures, as well as with electrolyte disturbances, heart disease, high fevers, especially febrile seizures in really young children. They'll sometimes have a kind of a benign seizure as a result of a high fever. Strokes and then substance abuse can all increase the risk of having a seizure. So seizure precautions in hospitals. In most hospitals, seizures precautions just refer to pad the side rails with blankets or things like that. However, it really should involve a lot of other precautions, such as being ready to supply oxygen and maintain an airway, making sure that the patient has a patent IV in case medications need to be given. I thought it was interesting in your book. The book says that bed rails are seldom the cause of an injury in seizures, so why do we pad them and neglect some of these other precautions? So management for seizures really depends on the type of seizure. But in general, we want to make sure that we are observing and documenting. We want to make sure that the patient is safe. So never put anything into the mouth of a patient having a seizure, never restrain them. It's always a good idea to put them on their side with a pillow under their head and to help protect them from injury. And then putting them on their side is also helpful in case they vomit so they don't end up aspirating. Acute seizures are treated depending on the type, but for a generalized seizure or the tonic-clonic seizure activity that we talked about, the two most common meds used are your Ativan and Valium, or lorazepam and diazepam. And the class of medications that these are benzodiazepines. And then also Dilantin, which is an anticonvulsant, is sometimes used. And the route of these medications during acute seizures is usually going to be IV. Okay, status epilepticus. This is a medical emergency. It's a prolonged seizure that lasts more than 5 minutes or many repeated seizures over the course of half an hour. Most of the time, status epilepticus is going to result from infection, especially infections that affect the brain, drug and alcohol withdrawal, and sudden withdrawal of anti-epileptic drugs. Head trauma as well sometimes can cause this. Again, this is a medical emergency. So our priority here is going to be our ABCs. We want to maintain the airway. We're most likely going to give IV push Ativan. Occasionally, sometimes diazepam IV, or it can be given rectally as well. But I would say practically in most cases, I've seen this treated with IV medications. So this slide is just some considerations for drug therapy in general for seizures, so not just the acute management. A lot of seizure medications, Dilantin, Depakote, Keppra, can be really toxic and have effects on your body and can even cause some really severe effects to your body, like decreasing your white blood cells. So most of the time we want to make sure these are at a therapeutic level, and many of these have monthly drug level tests that you must get taken by the lab before you continue your medication. An important consideration with Dilantin or phenytoin is that if you take Dilantin, you can't take warfarin, and vice versa. So Dilantin can greatly potentiate the anticoagulation effects of Coumadin. Some considerations for patient and family education. We want to stress compliance, and I'll say this again and again. I always prefer the word adherence to compliance. So we want to stress adherence with AEDs, and what AEDs means here is anti-epileptic drugs. So remember that stopping their medication can set off status epilepticus. So we want to make sure that they understand that they must maintain it and not just quit the medication. This can be kind of an issue because some of these medications can be very expensive. So we may need to enlist the help of social services or other resources to help the patient afford their medication. Safety with employment is important, and also some people with epilepsy are not able to drive, so that can definitely present issues with independence and their ability to maintain a job and have income. So don't neglect to think about some of those social issues that go along with our patients' treatment plans in general and medication costs. Okay, so something else that can affect the brain are infectious diseases. So what we're going to talk about are on the slide. So we're going to talk about meningitis, encephalitis, brain abscesses, and then Creutzfeldt-Jakob disease. So you'll remember from our A and P slide, we talked about some of the coverings of the brain that helps protect it. And we talked about how the meninges is several of those layers together. So the pia mater and the arachnoid. And so what meningitis is inflammation of those meninges. And you can, if it helps make more sense, I have a picture here, but if you also want to look at that slide from earlier, but this picture also shows it. Meningitis can be viral or bacterial. Most of the time it's viral, but the signs and symptoms and the presentation that you will see clinically are the same, regardless if it's viral or bacterial. It can either enter the brain via the bloodstream and crossing of that blood-brain barrier, or it can enter by some opening of the cranial vault. For example, if you had a car accident or an invasive procedure that then left a pathway for bacteria to get within the cranial vault. Meningitis is also more likely in community living situations like college dorms or military barracks. So this is why doctors recommend that meningitis vaccine before going to college. So some physical assessment signs and clinical manifestations that you'll see with meningitis: fever, headache, and photophobia. So nuchal rigidity is a big one too, and what that means is that the neck feels very rigid to the point where the patient may even have an impaired ability to flex the neck. You will also see increased intracranial pressure, which we're going to talk about more later. We're going to see decreases in mental status and LOC, which, as you remember, can be a bad sign for your neurosystem. And then we're going to see what's called a positive Kernig's and a positive Brudzinski sign. So you'll want to make sure and look at those videos to see how you elicit those. If you click on those links on your PowerPoint that you're using for note-taking, then that should take you to the video. So go ahead and look at those. So lab assessment, this is an example of when we're going to do the spinal tap. We're going to look at the cerebral spinal fluid for cloudiness, and then we're going to analyze it for the presence of bacteria or viruses. Also may do a CT scan, blood culture, CBC, and x-rays as well in conjunction with that to determine the presence of an infection. So drug treatment for meningitis, they're going to use a broad spectrum antibiotic. But one thing is tricky with meningitis when using an antibiotic, it must be able to pass the blood-brain barrier that we talked about earlier. So some examples that do pass the blood-brain barrier and are used in meningitis are Rocephin and gentamicin. Just to clarify though, of course, antibiotics are only used in bacterial meningitis, as we don't use antibiotics for viruses. Anticonvulsants are sometimes used as well, and that's to protect against the possibility of having seizures. Steroids can be used to decrease inflammation within the meninges and to help decrease intracranial pressure. So I think I talk about this a little bit later, so I'm probably getting ahead of myself, but your skull and your cranial vault is a closed system. So anytime that we have increases or inflammation going on in any type of our brain tissue or layers of protection with our brain, then that can cause some major issues and put actual pressure on our brain. Because there's only so much room there, and so there's only so much room for inflammation to occur. So they will use steroids to help decrease that inflammation and then in turn to decrease the intracranial pressure. Most important prophylaxis treatment for those who are going to be in close contact with meningitis infected patients or who are going to be in group situations is vaccination. Nursing management for meningitis, we're going to conduct frequent neuro assessments, including their vital signs and assessment of their level of consciousness. We're going to protect them from injury, especially related to seizure activity or their decreased or altered level of consciousness. We want to institute infection control precautions due to meningitis being relatively highly contagious, and then providing supportive care for pain and any assistance with ADLs. Excuse me. Okay, so now we're going to talk about encephalitis, which is the acute inflammatory process of brain tissue. So meningitis is the inflammation of those protective layers of the brain, whereas encephalitis is the actual inflammation of the brain itself, or the brain tissue. Some causes of it: viral infections such as herpes simplex, West Nile, also may be the result of a fungal infection. So signs and symptoms you're going to see: headache, fever, changes in level of consciousness, may see a rash, patient may have some paralysis, or they may have some Parkinson's-like movements. Treatment's going to depend on the underlying cause. So for example, if it was caused by herpes simplex, then they're going to use an antiviral such as acyclovir. If it's a fungal infection, they're going to use an anti-fungal medication called amphotericin. Nursing management, again, is make sure that it's very frequent with ongoing assessment and supportive care. Okay, another issue that can go on that's an infectious process within the brain are brain abscesses. And this is a collection of infectious material within the brain tissue that leads to an abscess. These are relatively rare. Most of the time you're going to see them in patients who are somehow otherwise immunocompromised. Like for example, like they have cancer, or they have AIDS, something that is causing their immune system to be compromised, are at the most increased risk for this. You do want to be careful though. Occasionally, if you leave an otitis media infection, ear infection, or sinusitis or dental infections and some other types of systemic infections, if you leave those too long and they aren't treated, then that can cause a risk for the bacteria to sort of start seeding and getting through that blood-brain barrier in the brain tissue, just because your bloodstream is kind of overwhelmed by bacteria. And anything that has to do with your head, so like ear infections and sinusitis, just because of the proximity of those infections to your brain. So making sure that we are treating infections like that promptly. Manifestations that you'll see: headache, usually worse in the morning, fever, different neurological deficits, and vomiting. So one interesting disease is called Creutzfeldt-Jakob disease, or CJD. And this is sort of like the human version of mad cow disease. So it's not an infection actually, and that it's caused by a bacteria or a virus. It is an infectious process caused by something called a prion. So a prion isn't a virus and it isn't a bacteria. It's not actually alive, but it can replicate and is infectious and causes the proteins in your brain to misfold. So that causes all manner of issue. It's contracted through the ingestion of infected beef, and it causes sensory, motor, and cognitive impairments. And CJD is universally fatal, as there's no treatment for this. Okay, so next we're going to talk about Parkinson's disease. So Parkinson's disease is associated with decreased levels of dopamine due to destruction of cells, and this then in turn affects the neurotransmission of impulses. So as you remember, we talked about neurotransmitters, and that dopamine is one of the neurotransmitters that our neurons use to send messages. Dopamine is one of the transmitters that allows us to have voluntary control over our muscle movements and make our movements slow and purposeful and smooth. And without that, we would have involuntary movements and movements that are not smooth and not purposeful. So Parkinson's in general is associated with a decrease in dopamine. So we know then that our motor impulses are not going to be transmitted appropriately. So some manifestations we're going to see with this: bradykinesia, which just means slow movement, tremor, rigidity, depression, and other psychiatric changes. So we see the muscle issues, and then we also see the depression and psych changes because, as you remember, dopamine not only plays a role in motor movement, but also dopamine plays a role in our pleasure and our motivation system within our brain. So treatment is going to be with what are called dopamine agonists. So why? Because these mimic dopamine in the central nervous system. So some examples of these are Mirapex, Requip. Another common one is called Cinemet, which is a combination of levodopa and carbidopa. And what these are is they're basically, this is oversimplified, but they're basically like dopamine that you take from outside your body and put it inside. So since your actual body and brain isn't manufacturing the dopamine, you take it externally. And do know that Cinemet, the combination of levodopa and carbidopa, is usually the initial drug of choice for Parkinson's. Okay, so I have an example here in this photo of what is called the mask-like facial expression that you will see typically in patients with Parkinson's disease. So some nursing process considerations: focus on the degree of ability to perform their ADL. So you want to enhance the patient's self-care ability. So we still want them to be able to do the things that they can do and just sort of support them to be more independent, encourage and teach them and support them in their independence. So sometimes my grandma's like in her mid-90s and still lives alone and very independent. And sometimes I'll go over there and I'll want to do things for her because she's much more slow at doing things than I would be, and it could kind of be frustrating, you know, waiting for her to do things much more slowly. But I know that she really values her independence, even if it takes her 3 times as long to do, you know, something that I could do instead. But I still just kind of sit there, suffer through the frustration and allow her to do that. And we always want to do that with our patients as well. We don't want to take over for them on the things that they can do, because they are often really struggling, especially, you know, with Parkinson's and movement disorders like this, struggling from a loss of their independence. So we want to still allow them to do the things that they can do, even if it's a little bit more slow. We also want to know our medications that we're going to use and the responses we want to see with those. Setting achievable and realistic goals, while still encouraging them to be independent, to socialize, to do recreational activities. May need to consider different home care needs and assistive and adaptive devices in the home, and a fall risk assessment while in the hospital, and also assessing their home for fall risk is important as well. All right, so we're going to briefly touch on this. I think you went into depth in this probably in Jerry, but Alzheimer's disease is a progressive disease that causes structural changes within the brain. So it might start out as simple lapses in memory and then progresses in stages until there's severe deterioration in the cognition and physical mobility of patients with this. Death from Alzheimer's, though, you can't actually die from Alzheimer's disease itself as a process, but from the complications of it. And usually death results from complications that have resulted from prolonged immobility. It's also important to know that Alzheimer's is just a type of dementia. There are several different types. Dementia itself is sort of an umbrella term with many different types of dementia falling underneath. So Alzheimer's is one of those. And Alzheimer's is caused by what are called plaques and tangles within the brain. So these changes then lead to impaired cognition issues with memory, language, attention, and judgment. So all of those different areas that we saw in that first color-coded slide of the brain, once those plaques and tangles build up within the brain, it can lead issues to everything that your brain is responsible for. So one interesting thing about Alzheimer's is it's diagnosed by symptoms, and it's only diagnosed after ruling out all the other causes of dementia. So to actually definitively diagnose Alzheimer's, we cannot do so until we examine the brain on autopsy and look at the brain tissue. But Alzheimer's is a disease that eventually affects the family more than the patient. So in the later stages, it becomes especially important to provide support to the caregivers, and that starts to become the priority as well. This is an interesting thing I found several years back. It was an artist who developed Alzheimer's disease, and he did a self-portrait over time after being diagnosed with Alzheimer's, and you can see how the changes related to that and the changes to his art. So the last thing we're going to talk about here in part 1 is Huntington disease. And this is a chronic, progressive, and hereditary disease that results in something called coriform movements. And the coriform just means rapid and jerky. So rapid and jerky movements, dementia, and behavioral symptoms. And this is genetically transmitted, and it's transmitted as what's called an autosomal dominant disorder, meaning that you only have to have one copy of the defective gene from one parent to have a possibility of having it. If anybody ever used to watch House, the character 13, her mom has this, and she tests herself for it. I bring that up because it's a very personal thing to decide to get tested for this gene. If you know that it runs in your family, sometimes people want to know if they carry the gene when they're younger. Usually symptoms don't manifest until age 30 to 50. So relatively young still, but some people want to know if they have this in their future, and some people do not want to know. So just know that it is very personal to each person, and not everyone feels the same way about knowing. All right, so this concludes part 1 of your lecture. So go ahead and watch the second part when you are ready to continue.